So this lecture is going about, we'll be discussing principles of outbreak investigation and response. So these slides I'm presenting, I adopted them from Matthias Boat from the Robert Koch Institute in Berlin. He's also a lecturer at the London School of Hygiene and Tropical Medicine. So in terms of an outbreak, why is it really so important, to invest in an outbreak? Because an outbreak, so it's important for us to really invest in outbreak because in most cases it is an emergence condition. So because of its emergence in nature, where you suddenly have people experiencing a disease, there's then an increase, there's a danger of an increase in morbidity and mortality due to whatever is causing the outbreak. Then because the number of cases of the disease will be increasing, there's also an increased burden on the healthcare providers. They will now be working more than the expectation, because the number of cases will be increasing because of increased mortality and morbidity. There's always anxiety and there's always panic. So it is of paramount importance to really make sure when you're investigating an outbreak, you understand the principles so that you address some of these issues. The other issue, which is very common among outbreaks, most of these outbreaks, they tend to be politicized now. I think if you currently we've got the corona epidemic, but if you look some of the political issues which are involved, in decisions making, issues to do with vaccine, issues to do with medications, and so many other things. So you end up having political and social pressure actually, with also the residents and the citizens demanding better care. So I think these are some of the issues which are critical. Why is it important actually to investigate an outbreak? So before we go into defining and into really discussing the procedures which are required, the steps, the principles in terms of really how to investigate an outbreak, it is critical for us to understand some of the definitions which are key for us to understand an outbreak. One of the terms which is critical for us to enter is a cluster. So a cluster, usually when you are saying a cluster, we have got cases aggregated over time at a place. And thus, if you have got maybe a certain place, you look at the number of cases which are occurring over time. You can have a cluster of cases actually which will be occurring, within a specified period, over a specified period or period of time. Then there's a question now, whether can we really classify a cluster as an outbreak? And so in terms of the definition now of an outbreak, by an outbreak, we mean that we have got more cases than expected at that time in that place. So I think it has to be very, very clear. For us to really say we've got an outbreak of a disease, it means we are getting more cases than expected at a specific time and in that place. Remember, as I defined, a cluster actually refers to to cases which are occurring within a certain place over a specific period of time. But when we are saying now we are having an outbreak, it means we are having more of those cases, remember, than expected. But for us to know that we are having more cases than expected, what is critical is we need to understand some of those issues which are common. We need to have background incidents. Background incidents, it just refers to, remember, there's the word expected. And so we want to know before what was the incident. And it is so based on our knowledge of that background incidents, we'll be able then to really know, are we having cases which are more than expected. the current incidence rate or the attack rate, which is the number of number of cases developing per time, is also critical for us to understand if the cases are increasing more than expected. Then in terms of the assumption in an outbreak, we assume that the cases have a common source or they are related to one another by pathogen and of transmission. We are going to discuss this in the following slides. Then I think from the previous lectures, when we were defining some key terms which are used in epidemiology, we've also discussed some of the synonyms or which are similar to an outbreak. An outbreak can also be referred to as a what? You can call an outbreak an epidemic. So those words, they can be used interchangeably. I hope you also remember the definition of some of the keywords which we defined when we started this whole lecture around, and when we started these lectures in epidemiology. We defined a pandemic, we defined an endemic, we defined an outbreak, and we defined an epidemic. So please go back to your notes and make sure you revise on some of these issues. So it is critical before we really say this is an outbreak. It is of paramount importance for to be able to distinguish between true or a false outbreak. In terms of true outbreak, the cases have to be related. Why they have to be related? Remember, from what I said on the above slide, where I mentioned that the case should have a common source, or they are related by one another in terms of transmission. So a true outbreak, the cases are related of the same the same disease. But we can have we can have false outbreaks. So usually in false outbreaks, these are sporadic. The cases are not related. They are not coming from from the same disease. They are not really coming from the same pathogen which is causing this the cases. So usually, how do you get alerts in terms of how do you get alerts in terms of knowing there might be an outbreak? One of the most common source where as countries, as health practitioners, as public health providers, as epidemiologists get information in terms of whether we are likely to have an outbreak or not is from the surveillance. I hope we discuss surveillance. Surveillance, these are the systems which are put within the ministries of health, and these systems, they're actually responsible for collecting data. So through this collecting data, you then realize, you might then see we are reporting more cases than the previous trends, and because of that, that can actually give information to say they might be we might be having an outbreak. In our Zimbabwe setting, I will try and share a symbol. We have what we call the weekly disease surveillance reports, and from this weekly disease surveillance reports, every week within the ministry, they summarize the number of various diseases in the report. So if they note an increase in the number of cases, based on that weekly surveillance report, they can then really maybe they detect if there's an outbreak. The other source of alerts in terms of outbreak is clinicians. Remember, the clinicians, they're like the first port of call and the first contact with patients. We might actually notice maybe at your clinic, at your hospital, we are now reporting more patients with a certain disease. And because of that, and because of you now have more people reporting, actually it can be a clue to say you might be having an outbreak within the vicinity of that clinic. Remember, these days we talk of One Health. where there is very close relationship between, between the veterinary services, and in the health sector and the human health sector. So because of that, we can have some outbreaks actually being reported, because we've got outbreaks which are caused by zoonotic diseases. And these zoonotic diseases, these are diseases which are transmitted to human from animals, with examples of diseases like anthrax, diseases like rabies. Then the members of the affected community themselves, actually, they can actually assist in the reporting in outbreak, because they are the affected, and they can actually raise the alarm to the responsible authority after noticing among themselves people reporting more with the disease. Why is it important to investigate an outbreak? Number one, it is important so that we implement, control, we implement, control measures. Some of these outbreaks, they can be very, devastating and devastating. They can lead into, they can lead into severe morbidity and mortality. So because of the associated mortality and morbidity, there's then need to quickly implement outbreak control and measures. The other reason is to understand the magnitude of the problem, that is the size of the outbreak, the severity of the illness, the potential further spread. So by really investigating an outbreak, we then understand some of those issues which are associated with morbidity and mortality. Then it's also a research opportunity, not really being interested by doing the research, but some of the outbreaks, they are caused by a known disease. So by actually investigating an outbreak, you will then be able to understand the disease better, especially if the disease is unknown. But for known diseases, it might be an opportunity to understand the disease better. So the other reason is training of staff, so that in case we have another outbreak, they'll be more prepared to address that outbreak. Then some of the things which can push people to conduct outbreaks include political pressure. It can be legal obligation. It can be public concern, or issues to do with programming. Maybe you want to assess, maybe implementing a vaccination, a vaccination program. You want to see if this program work, or maybe you want to assess whether a program has been working. So you want to consider eliminating the program. So now coming to the actual outbreak investigation. How do you conduct this outbreak investigation? There are 9 steps, there are 9 steps. There are 9 steps which are supposed to be followed when you are conducting a proper outbreak investigation. The first step is, 1, you need to prepare for the field work. Number 2, you need to establish the existence of an outbreak, because, as I said, you can have a false outbreak versus to a true outbreak. So if you don't really establish whether what you want to investigate is a true outbreak, you might end up wasting resources. Number 3, you need to verify the diagnosis. Number 4, you need to establish a case definition. This is very critical to make sure you have got a case definition. Number 5, you need to identify and count the cases. Number 2, you do descriptive epidemiology, where you describe your outbreak in terms of time, place, and person. Number 7, you formulate and evaluate an hypothesis. Remember, as I said, investigating an outbreak is an opportunity, actually. It's an opportunity which you can actually use to perform research, so that you have got better understanding, of the disease. If it's a new disease or if it's a known disease, you try to understand it better. Then after you formulate your hypothesis and evaluate the hypothesis, which is testing of the hypothesis, You implement control and prevention measures as early as possible. And that you implement control and prevention measures as early as possible. Why? Because as I said, if you don't implement some of these things at an early stage, you might end up having severe morbidity and mortality. Then after all this, then it's very critical to communicate the results. So I'm going to discuss these steps one by one. The first step, which is you need preparation for fieldwork. So how do you prepare for fieldwork as the first step? So the first step, usually it is very critical, before you really go out to invest in an outbreak, to acquire knowledge if necessary. Some of the diseases, yes, you might be a clinician or someone with medical knowledge, but I think it would be good at times to just have a recap of the knowledge in terms of the disease which are going to be investigated. You understand, its pathogenesis, its diagnostic, the case definition, and some of these other things. And how do you acquire that knowledge? You acquire it through reading the literature, or you can have a resource person who can actually give you this information. So it's important before you go out to investigate to make sure you have got an understanding of the disease which you are going to, you understand the pathogenesis and the physiology of the disease which you want to investigate. And as you go out, it is then critical to make sure you go with the necessary, equipment which is required for outbreak investigation. What are these important equipment? You need a computer, you need communication, your cell phone, and personal protective equipment. Because most of the diseases which cause outbreak, they are infectious, and so you need to be very careful as you go out for outbreak investigation. Because if you are not careful, you end up really, getting infected in the process of outbreak investigation. Some of the outbreak investigation, they require you to collect specimens. So it is very important to make sure you have the necessary tools which are required to collect specimen. Not just collecting. Remember, you need to collect the specimen, you need to store the specimen, and you need to later transport the specimen to the lab. So it is critical to make sure you have all those things with you ready. Then, as part of the preparation for the field work, there might be a lot of administrative issues which might need to be done before you go out, for an outbreak investigation. There might be, it depends where you're going for, to investigate this outbreak. But in most cases, we have had, in some scenarios, we have had people actually coming abroad to assist, developing countries in fighting an outbreak. So because of that, you might need to do things like travel permissions, passport, visa, some of these funds. I think things like coronavirus. People are coming from the developed world to come and really offer technical assistance to people in developing world. In cases of Ebola, we have had people really coming, abroad to come and assist. So as part of the preparation, actually, you might need to really involve some of those things. But as you prepare, as you go out, it is also very important to really understand your terms of reference with what is expected from you. Is it leadership? Is it expert advice? Is it assistance as you are going to assist in the process of outbreak investigation? Number two, you need to establish whether there is existence of the outbreak. Remember, as I said, there's a danger of actually assuming there's an outbreak. Well, there's no an outbreak. And how do you assess this to see if there's an outbreak? Remember, as I said, the basic principles is you are comparing observed with what? With the expected. And how do And how do you assess this? Remember the expected incidence, and what do you expect to see? You're comparing, and if you are seeing more than the expected, then you might be suspecting incidence. There are some diseases which have seasonality, and where the incidence of the disease depends on seasons. I think there we have got some health conditions or some infections which are more prevalent during other time of the seasons. Then there are other conditions with no seasonality. So if you see incidence which is more than the expected based on season, then you can actually then suspect an outbreak. What are the sources of information in terms of really seeing whether we are seeing more than the expected? You can be used published epidemiological information, surveillance data, hospital records, or maybe a community survey. But in some of the diseases, we have what we call thresholds. These are very common for malaria. If you go to most clinics, they have got charts within the clinics where they actually draw graph where they put the threshold in terms of the expectations. So thresholds, I think we have a lecture maybe later where we will discuss really how do you this type of thresholds and how they are developed. But generally, yeah. So if you are having a threshold, it's like the minimum. So if you are then going above the threshold in terms of your numbers, you can then suspect there's an outbreak. Then, as you try to confirm truly if there's an outbreak, then there's a danger of having bias. How do you remember what are some of the things which can actually really raise a false alarm where you think there's an outbreak, but there will actually be no outbreak? Number one is an improved reporting system here. If people start reporting a condition more than they used to report, you might start having more cases than the previous periods, and because of that, it then appear as if you are having more cases, but what will have happened is just an improved reporting system. Then in most cases there might be a change in case definition. Remember, in terms of case definition, we talk of sensitivity of a case and of a case definition. If you have got a case definition which is loose and which is like strict, it means, let's say it's for a condition, and whatever condition you are looking into. If the case definition for that condition is strict, it means in terms of the number of cases you report, in terms of the number of cases which you report, there might be few. But if you broaden or widen your case definition, you actually might have start picking more cases as opposed to having a case definition which is less sensitive. Then you can also have people start to report a condition. Why? Because they are now more aware of the condition, and it may be during those days, the media, the government, they start really to publish, to give people information on a certain condition. So because of that, actually, more people might then start to report. More people may then start to report, or present to clinic with the condition. Why? Because they are now aware of the signs and symptoms, the prognosis, the morbidity and mortality of whatever condition. So because of that, you might have this sudden increase in cases, which actually might then be confused with an outbreak. Then the other issue which might cause a false alarm is a sudden increase in the population. So if the population increases, then it means you've got more people, and you're likely to have more people reporting a certain condition. So because of that, that can also give bias in terms of the number. So it is very, very critical before you really go out to investigate, get an outbreak, to make sure there is no bias. Because if you go out, and you prepare yourself and start doing all these things, but at the end of the day, at the end of the day, maybe there are some of these issues which I have raised. It will not really make a lot of we have wasted resources. So it is of paramount importance to really make sure when you go out, some of these issues should have been sorted. You should be sure, and you need to make sure you prevent bias. Then the next step now, you are now sure we are now sure if you're now sure at least what I'm going to be investigating is an outbreak. The next step is you need to verify the diagnosis. How do you verify the diagnosis? Either you can verify the diagnosis by reviewing clinical findings, and in terms of the clinical symptoms, what these people are presenting with. You can review the lab diagnosis, or actually you can on top of this, maybe reviewing yourself the clinical findings, reviewing yourself the laboratory diagnosis. You can actually call a specialist who will then assist you in terms of, for this outbreak, what exactly do you then need to be able to verify the diagnosis? Are you going to use clinical findings, or we are going to use a lab? But it then depends. With the disease. But most of the diseases, usually you might need to confirm one, just to have a lab diagnosis, maybe a few of the cases. Then from there, you can then epi-link the other cases to assume. Remember, as we said, in case of an outbreak, there's the pathogen is the same. So if you just diagnose a few within the same population, just to confirm it, you can then actually use clinical diagnosis for other. To also verify the diagnosis, you can visit the patients themselves, you see them, you talk to them, you assess their prior exposure, you check their idea of the disease, you check their knowledge, and so forth. So really, so you can really combine a lot of other aspects for really you to be in terms of really verifying the disease. The next step, after you verify your diagnosis, you then need to have a case definition. So how do you, now remember, at the end of the day, you want to be able to really to know who is a case and who is not a case. There are several ways and which you can use actually to define your case. As I mentioned in the earlier stage, in the earlier slide where I was discussing about verifying a diagnosis, you can have your case definition clinical. By clinical, it means you're just using the signs and symptoms to define your case, or you can use a lab criteria. It also depends. It also depends with the disease. Some of the disease, the clinical diagnosis alone might be enough, but for some of the disease, you need both clinical lab and both clinical data at the same time with lab confirmation. I take, for example, of a disease like COVID-19. For COVID-19, when you are defining a case of COVID-19, the clinical diagnosis alone is not enough here. Why? Because the signs and symptoms, they're not specific, and it can be the usual flu or something, or another respiratory tract infection. So, but because of the non-specificity of the clinical signs, you then need both a lab and the clinical diagnosis. On top of that, you can also use what you call epidemiological criteria, where you epi-link, and where you epi-link. By epi-link, what does it mean? Remember, I said in some of the conditions, it might not be possible for you to really, test everyone. The testing might be complex or might be expensive. So because of that, you only need to test a few. Then because they're in the same population, they've got the same symptoms, they are, maybe it's the same source. Based on that, you then assume the others, and those who are getting the disease is because they're linked to those ones. So that's like an epidemiological criteria, where you're also defining your case as someone who has been in contact with with another case, or residing in the or residing in or residing within the same vicinity. Is as you process your as part of your case definition, it is also critical to restrict it in terms of time, in terms of place, in terms of in terms of person. Those are examples, and because remember, we say by an outbreak we are having more cases than expected within a specified community over a specified period of time. So as part of your case definition now, you need to make sure you put these elements in your definition. And you have to constantly apply to all persons. And now, as you go out to investigate your outbreak, you need to make sure you are applying that same definition consistently. And as part of that case definition, you don't include the exposure which you want to test. Because at the end of the day, you are going to assess the relationship between your exposure and the disease. But for many diseases, for many of these conditions, we always have predefined case definitions, and we have predefined case definitions. I will try and share a list of some of these case definitions for some of these conditions. So yes, you might need to then fine tune it a bit, maybe in terms of time, place, and person. But the clinical, the lab, usually their standard definition. If it's for COVID, if it's for malaria, if it's for whatever disease which you'll be studying. Then your case definition. I think I briefly discussed some of these issues. Usually, for a case definition, you want a case definition which is highly sensitive. By highly sensitive, we want to make sure you don't, by highly sensitive, it means it picks most of the cases, and it picks most of the cases, and you want those cases which you pick to be. Yeah, I think I might need to explain it a bit. But you want your case definition to have high sensitivity, but the danger of having a case definition which is more wide, which is more inclusive, it tends to have, you tend to have a high number of false positives, and I think this is not, because if you have got high sensitivity, you end up having a lot of false positives. Then you need to include as many possible of non-cases as possible. So you need to make sure it is highly specific, and by that, it means you have less less positives. We are going to discuss these issues of sensitivity and specificity when you are discussing diagnostic test and screening test. So in this scenario, your case definition is more like a test which you are going to use to identify or pick your case. So these concepts of sensitivity or specificity, they then apply in terms in relation to that. So the case definition, as I said, it should be simple, quick, and cheap. But usually, yes, as you then go out to conduct your outbreak investigation, it then becomes difficult, to really stick to some of these things. People end up really compromising or really changing some of these things. But one of the things which is important, we need to apply it consistently to all your persons which you'll be dealing with. So, as I said, in terms of these case definitions, we have a hierarchy. We have a hierarchy in terms of these these case definitions. we have what you call a possible cause, a possible, that's like a suspected, and a suspected case. You have a probable case. You have a confirmed what? A confirmed, if I confirm the case. So yeah, I think there's an example of Ebola, which is listed down there. But actually, I think I will give you the one for COVID-19, where you see to say, when do you suspect someone to have COVID? When do you say this one is most likely a probable case? But usually a suspected case is mainly based on signs and what, and signs and and symptoms. Then a confirmed case, usually you then do a laboratory test. Now there's the lab component now, which comes into play. And so just understand there's this hierarchy, in terms of these cases. You can actually classify them further. Maybe just an alert, it's a suspect, it's a probable, it's a confirmed. But these, they differ depending on disease, and they also differ depending by the people who are using it, and by the people who are using it, and also for different purposes. If you see in the example of Ebola, alert is mainly used by the community. You want people to know something might be wrong. Then the suspect is mainly used by the surveillance team, and they decide on whether to transport the people to the hospital. Probable and confirmed, those are used by by clinician. Why? Because they need to isolate and transfer. They need to isolate and transfer your patients for workup and further management. As I said from the previous slides, lab confirmation is not always necessary for all cases, and it possibly just for the first few cases to be able to confirm the existence of an outbreak. So because of that, as I said, it might not be possible. I think I mentioned this, which I need to mention. I'll give an example of anthrax. Some of these outbreaks, they are caused by pathogens which are very toxic, which are very harmful, and actually they can have serious effects. So because of that, some of the outbreaks, we don't do lab confirmations for the fear that actually you might end up harming people. It might be difficult to transport the samples and the specimen. So we'll just stick to the clinical diagnosis. So these are not very clear, but if you look, this was an example of Uganda, where they are using the case, and these are the case definitions I mentioned. You have your alert, you have your suspect, you have your probable, you have your confirmed. Who is using? It's used by whom? What is it used to decide? And what is the criteria which then really define? But if you see, there are three things, and to try as you move from an alert, from an alert to a confirmed, and in terms of case definitions, there is simplicity. Usually the confirmed one, it's simpler. Why? Because you need a test. If someone is positive, and if someone is positive or negative, so it's more simpler as you move down. Why? As I said, it's about whether it's a positive test or it's a negative test. Then in terms of sensitivity, in terms of specificity, and as you come down from the alert going down to confirmed, the sensitivity, the specificity increases, and the specificity increases. Then the sensitivity, it more or less remain the same, as you move from these case definitions from alert to to confirmed. So I think this is a bit complex, but just understand these criteria, whether is alert, suspect, probable, confirmed. Yes, they are used by. You can develop those criteria, And their use actually would then depend with who is using them, what are they using for, and what is the criteria, and they then differ in terms of their simplicity, their specificity, and their what, and their sensitivity. Then one of the things which is important for you to understand in terms of this case definition over time, when you are starting really, to investigate an outbreak, the emphasis is to make sure you have got a case definition which is which is highly sensitive. Why do you want an outbreak which is highly sensitive? You don't want to underestimate the extent of the outbreak. You don't want to miss some of the cases. And so you want a case definition which is sensitive, which picks most of which picks most of the cases. But remember, if you have a more sensitive case definition, you tend to have high false positives. Then, but as you go over time now, we are more worried about a definition which is more specific. Why do you want a definition which is more specific? Because now you then need to test your hypothesis. You then need, to know what is causing the relationship between the exposure and and the outcome. So because of that, you need to make sure you have valid results. And for you to have valid results, you need to make sure your definitions are are specific. Because if they're not specific, you end up getting associations which are weak, which are maybe you overestimate or underestimate. Then the next stage, which is stage number 5. So we are now, first you have prepared for field work, we are out in the field, you are sure that there's an outbreak, you have verified the diagnosis, you establish your case definition. With your case definition now, you can then start to identify and count your cases. That's the next step, which is step number 5. So usually when you are doing outbreak investigation, it is of paramount importance to be able to identify the first case, or what we call the index case. So in most cases, if you identify your your index case or your first cases, they'll then actually assist you to really pick and trace in terms of how this whole outbreak started. But in most cases, when you are doing your outbreak investigation, the first case which you might pick is not usually the first case, and you might really see someone maybe who has presented the clinic, but maybe they got that from someone maybe who has not reported the clinic, or maybe that person might have died. So in most cases, it doesn't mean the first person to be seen is the first person of the outbreak. So there's this need actually to then really follow up so that you get your first, you get your actual case and how it actually started. And how do you do this? Usually it's by casting your net wide. You check on all health facilities, you alert the public to come for themselves with the disease. You can actually conduct a survey within the population, just getting the dates when their deaths, when all these things and it started. Or you can ask the case patients. And as you identify and count your cases, it is important to collect important information. What is this important information which you want? So usually you don't just, when you're going out for an outbreak investigation, it's more like we are going out to, to conduct research. And before you leave, actually, before you go, remember I mentioned the issue of, knowledge, issue of literature. It is of paramount importance, actually, to kind of design, to write a proposal, just like a concept note, really summarizing what you want to go and do. And as part of that, you include a data collection. What's a data collection and a collection tool, like a standard case report form, and where you need to collect information about identifying information in terms of their name, their address, their telephone, collecting demographic information, their age, their sex, their race, their occupation. Then clinical information is also very important. And in terms of the disease, when did the disease started, what are the symptoms, hospitalizations, if someone is admitted, the treatment which they receive, and the outcome, whether they are, whether they will survive, whether they were cured of the disease, whether they died, or they're still actually really nursing some of the outcomes of the disease which we're investigating. Then, as part of also, remember, at the end of the day, when you're collecting this information, we want to really assess the association between the outcome and the exposure. So it's also very important to also collect information about information about exposure. And it really good. What are the possible things which might, in this case, you're doing an outbreak an outbreak investigation, maybe for COVID-19 cases. Some of the exposures might be maybe going to a gathering, going to shops, not wearing a mask, blah, blah, blah. So you need to really get that information as part of your things. But at the end, you then need to assess the relationship between those who get corona and those who are exposed to some of those things. Then, as you collect this information for outbreaks, it is important to develop a line list. It is very important and very critical to develop a line list. A line list now, we are then listing all your cases which you are identifying as part of the outbreak investigation, and you'll be putting key information, and it depends. You can put, like in this example, you put the initials, the date of onset, how they were treated, the symptoms, their age, and something like that. And so usually, as you're doing an outbreak, it is of paramount importance to make sure you create a line list of all the cases. And you create a line list of all the cases which you identify. And in that line list, you put information. One of the challenges which we see with outbreak investigation is outbreak investigation is you tend to have incomplete line list, and the line lists, they won't be complete actually, and they won't be complete. Maybe other cases are missing some information of other, it also won't be available on the line list. Then the next stage after you identify your cases, you now have your list of all the, and you now have your list of all your, you now have the list of all your cases. You then describe your outbreak, and you want to describe your descriptive epidemiology, where you describe your epidemiology in terms of time, person, and place. So in terms of time, usually you draw what we call an epidemic curve, which is a type of a histogram, where it displays the magnitude of in terms of the number of cases by time. It shows trend by time, and using that actually it might allow you to predict further course with how the disease is going to progress. From that, you can also deduce the time period of the exposure. You can also use it to define the type of the epidemic. Remember, in the next slide, I'll show you actually with this curve, as you draw this epidemic curve, there are epidemic patterns. So from there, you should be able to really identify the pattern. So these are examples of epidemic curves. The first one, we call this one a point source. A point source, it means people got the infection from, what can I say, from one, they're getting it from one source. And so usually in such type of outbreaks, you have, usually there will be no cases. Then thereafter, the cases will go up, 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 up. Then the cases will then, and it usually the examples of point and of point source exposure, where you are getting the things from one source. Maybe it might be infected water, maybe it was at a party, and maybe it was at a party or at a function, maybe there was food poisoning, maybe it's a case of, yeah. So in that case, the cases goes up, then from there, they go down. Then I give an example. If it was a party, it means the party is going to stop. And so from there, it means you no longer, you're no longer, let's say you're not going to get more of the exposure. So if it was food, if it was at a wedding, all of you eat the food will be finished. Then you start having cases and it going up. But this is then different now from a continuous exposure. Continuous exposure now, it means now the source, and it means the source, for continuous exposure, what does it mean? It means the source of the exposure is always there. So you will not get this typical up and down, but we have this gradual increase, and there are all these there are all these up and downs, up and downs, up and G, and it's up and down. So yeah, it's not like really the typical one. So you've got this up and downs because the exposure is always there. So you can have multiple peaks within the G, within the epi curve. Then you have another type now, which is called a propagated outbreak. A propagated outbreak, it means now people are getting the disease, then they are then passing the disease to others, which means it's more of like propagated. It's not like a point source. And how do you see it? It's like this. You have got multiple epidemic with like this one. It picks up, it goes up, it goes up, it goes, and it's very typical. And you have got this typical increases, and it was why you have got people getting the disease. Those people are getting the disease. They then spread the disease wherever they are going, and this is common now for infectious disease. Diseases like measles, where you have got multiple caves actually really showing slight. Initially they are like small, and then they gradually multiply. Why? Because there are more people who are getting the disease. So because of that, it becomes propagated. But later on, as you start implementing outbreak control measures, the curve will then start going down. So that's the first one, where you describe the outbreak in terms of time. Then the next, you describe the outbreak in terms of place. You need to know the geographic extent, of the disease. And how do you do this? You can draw this, but you can illustrate this by what we call spot maps now, where you then put the residents, and maybe you've got a case. For every case you have a map, and on that map you tick, and you put tick or whatever marks or dots on the map in terms of their residence, in terms of their their place of work or where they go for recreation. Then from there you can actually see how your cases are spread. You can also show spot maps. You're just showing the cases themselves, and you're just showing the cases themselves. But you can use what we call area maps. For area maps, we are using attack rates. What is attack rate? Attack rate is the incidence now, and is the current incidence, where you are actually showing which places are having more cases at a certain time. So spot maps and area maps, they are different. The difference being spot maps, you're just showing where the cases are emanating from. But area maps, they then show which areas are you having more incidents or new cases occurring within a certain period of time. So these are examples of spot map. The black dots, they are showing the cases. Then area map now, and if you see an area map, the difference between an area map now, remember, there's a rate now, there's a density, where you say in these areas, these areas is white, so it's 0. But with these areas where there is this shade, whatever, the light shades, there are 1 to 2 cases. But these darker areas, they got more cases, which is 11 to 10. So as I said, area maps, they show the incidence, and they show the incidence. I think you've seen, I'm not sure if in Zimbabwe we have, I think we don't, I'll share again one of the COVID-19 weekly reports and weekly, daily bulletin where they report the number of cases, But in those ones, yes, there are maps for Zimbabwe. There are maps for Zimbabwe where they put circles, blah, blah, blah. Those are not like really, they are more of spot map, not. You can look into that. I'll give them to you. You can also really look into them and try and see what exactly are those things. Then the next thing, you then describe your outbreak in terms of person. Who is the population? Who is affected? And in terms of their characteristics, the age, the sex, the race, the medical status. Then at the same time, you also want to see for this person, what are the exposures this person have, which might have put them at risk of getting the disease? What exposures do you might need to assess for the persons? You need to assess the occupation, their occupation, their environment, their food, their water source, their air pollution, their practices, which can go beyond, traditional practices. Then you also need to get whatever medications they are getting, maybe if they are abusing drugs and all those other issues. So for the person now, you want to get more, because you then need this information to assess, and you then need this information to, when you are now assessing your relationship between outcome and and exposure. Then the next thing is, after you collect you have identified your case, you have described your outbreak in terms of time, place, and person. The next thing you need to do is to formulate an hypothesis. Remember, when you are discussing descriptive epidemiology, we said descriptive epidemiology, actually, it can assist us to actually really formulate a hypothesis. So based on your descriptive epidemiology, whatever you found in terms of, when you are describing epidemiology in terms of time, in terms of place, in terms of person, you can actually formulate a hypothesis which can assist you to address any of those following. Number one, it can assist you to address the source agent. That is, what was the source of the pathogen or whatever which was causing the outbreak. That hypothesis should assist you to address the mode of transmission, and it can also assist you to address the exposures. And it can also assist you to address the exposures. Remember, an hypothesis is just an assumption, and it's an intelligent guess. And it could, now we've got this outbreak. Maybe it is a cholera outbreak. In terms of agent, you need to kind of really guess what was the possible agent which might have caused this. And in terms of transmission, you need to have an assumption on a guess in terms of its mode of transmission and what are the possible exposures. Then from that now, whatever hypothesis you formulate or assumption or intelligent guess you have, it should be testable. And as I said, in terms of the sources where you can get your hypothesis, I mentioned, which usually one of the sources where we get our hypothesis is from descriptive epidemiology, after we have described our epidemiology in terms of place, personage, and time. But you can also really generate your hypothesis based on established knowledge, case patients, their homes, and patient groups. You can also discuss here and with the local health staff. They can assist you actually in coming with the hypothesis, or you can actually use outliers. Some of those people and some of those You can actually use the outliers actually to really assist you in formulating your your hypothesis. So as you test after you've developed your hypothesis, remember you have your data, you have collected your data, it's on a line list, you have all those information about the patient, and you have your hypothesis. You then need to, as part of testing your hypothesis, we have what studies actually which are often used to investigate outbreaks. The common one being in cohort study, but remember cohorts, in a cohort study, you became comparing those who are exposed and those who are not exposed. Then from there, you can then calculate the risk, which is incidence, we have done this in the previous lecture in terms of the measures of association for a cohort study. So a cohort study is the best technique actually if you can do it. If you can really conduct it to, as part of your outbreak investigation. Why? Because remember when we discussed a cohort study, it helps us to understand the relationship between an exposure and an outcome. And there's this element of follow-up. So because of that element of follow-up, it will be easy for you to really measure incidence. So a cohort study can be used to test your hypothesis, calculate your measures of association, and many other things. I'll not go in detail in terms of cohort studies because we've discussed this. The other thing the other method which you can use is a case control study, and it is a case control study. There's another study design which is often used to investigate outbreak. Remember, for cohort studies, we are classifying our study participants based on outcome. But for a case control, we are classifying our study participants in terms of the outcome, those which are diseased and those who are not diseased, and we then look for their exposures. And a case control study usually is the most common study design which is used to investigate outbreaks, and it is the most common. Is the most common. Why? Because it is very simple. But I hope you remember when we discussed during the lecture around study design issues to do, challenges of selecting your controls, and how do you then select your controls? How do you remember with your controls, they should be more or less the same as your cases, except for your outcome. Then in terms of your measures of association, I think we've discussed this, where we say for your case control studies, you do your odds ratios and all those things. And your odds ratio is your measure of is your measure of the strength of association. So I'm not going in detail in terms of how to do. You can go over these examples in. Then just a warning, now you have your data, you have decided which method which you are going to use. You need to be very careful, and if no good hypothesis can be generated, an analytic study is likely to be a waste of time. So before you really decide to say, for this, I need to do this type of study, you just need to be careful and be sure you have a good hypothesis which is testable. And remember, in terms of exposures, you need to be sure you have got one which you are kind of like really suspecting that this might have caused this outbreak as your primary exposure, so that as you try to test it, you won't waste your time. Then the next thing now, remember, and the next thing, you have got describe your hypothesis, you have described your outbreak in terms of time, person, and in place. You have tested you have formulated an hypothesis to try to see what, remember, the purpose of formulating an hypothesis and evaluating is you want to see what actually might have caused this outbreak. So based on those findings, which you have found from your analysis, your analytic study. You then use that information to implement outbreak control and prevention measures, and these should be implemented as soon as possible. So how do you remember? If you remember our epidemiologic triad, where you've got our agent, our source, and our reservoir. So most of the control for most of the infectious diseases, which often cause outbreaks, our target actually is really to target that epidemiologic and to target elements of that epidemiologic and its control, where you want to destroy if it is food which is contaminated, if it's water you want to disinfect, we want to control reservoir. We want to, those with cases, those with conditions, we need to make sure we treat them to avoid carriers. Because if you have carriers, these carriers actually would then actually really continue to spread the disease, and the outbreak won't be able to be controlled. You want to make sure you do contact tracing. I think we have had this issue of contact tracing, which has been very topical, and very, it was discussed much, under this COVID pandemic, where you need to make sure if you get a case, you trace their contacts, you make sure they are, because if you don't address those contacts, they'll keep on spreading the disease. Then how do you interrupt transmission or exposure? And you talk of environmental hygiene, personal hygiene, use of protecting gear for diseases which are transmitted by a vector like mosquitoes. You talk of issues of destroying breeding sites, then avoiding invested areas. Then in terms of the host, you want to make sure the host the host is able to the host is able to resist the infection. How do you do this? You can give vaccination, you can give chemoprophylaxis, and you can talk of nutrition. So this is an example. This is a famous. I hope you know the John Snow issue, and this is the case in cholera. And in this case, the epidemic, it was a point source. It was a point source epidemic. The cholera resulted from people, drinking water from a tap, which was like poison or something like that. So when they just closed, in this case, just closed the source, the case were like picking. But as soon as you closed the source, and it was the extended, then from there the cases just disappeared. So really, for you, your control measures should be guided by your research, and that's why you really go out to investigate. So that research you do, you go into the field, should kind of really assist you in making sure the choice of your control measures are are evidence-based. You're not just doing things haphazardly. Then the last stage, which is after you have done everything, you need to communicate your results, and you need to communicate your results, and this can be done through an oral briefing to the local health authorities in charge of implementing control, telling them what did you do, what do you find, what should be done, and it should be very clear, convincing, and scientific. You can also talk to the media, but remember, in some countries, it can be very sensitive as a healthcare worker to find yourself talking to the media. So you need to understand what are the within your country, what are like the guidelines for you to communicate outbreak issues to the media. Then remember, as you communicate to the media, it's also very important to conscientize the media. And I think you've seen the dangers now of not really informing your media correctly. They end up spreading falsehoods. So you can also have a written report, and which can be, either something which you can publish or something which is more scientific, which you can share with colleagues so that they can use it for future reference in case they are similar, situations. So as I mentioned from the start, to say an outbreak is usually an opportunity for research, and it helps you actually to understand this disease, and this disease, whatever this you're investigating more. If it's a newer disease, it also helps you to understand. If it's an already existing disease, it will help you to understand it much better. I think this brings me to the end of this presentation. It was a long presentation, more than an hour. I think, yeah, the issues to discuss were long. So the other slides here, yeah, you can just go through them. I'll share with you this. I'll share the notes with you. Then this is a good reference book, Cases in Field Epidemiology. Actually, it's a good book. It will assist you to really understand some of these issues with how do you conduct some of these outbreak investigation in some of these field epidemiologic topics. Then this list is just a list of some of the sources which you can go to get more information about outbreak, what's investigation. Otherwise, I thank you. So go through this material and understand outbreak investigation. It's a very critical aspect within our setting because we always have a lot of these outbreaks happening. So it's critical for you to understand so that you'll be able to assist this when you go, out within your districts, within your communities, because you always have outbreaks of various diseases.